Hello everyone. Before I start, I'd like to thank the organizing committee for inviting me to be here. My task today is to share with you the practice of antibiotic stewardship in the public hospitals of Hong Kong. And for this talk, I'd like to declare new disclosure. And back to basic, the antibiotic stewardship is to optimize the selection, dosage, route, and duration of the antimicrobial treatment. And of course, our primary goal is to help to optimize the patient's outcome and also to avoid those unwanted side effects, such as the toxicity of the drugs and selection of the pathogenic organisms. And of course, nowadays, the most important concern on the use of antibiotics is the emergence of resistance pathogens. And one fundamental question is our practice of the antibiotic stewardship evidence-based? And if you browse through the literature in the past 15 years or so, you can see exponential rise on the literature reporting the effectiveness of the antibiotic stewardship program. And for the interest of time, I will select two papers to share with you today. And the first one is published in Lancet in the year 2016, which is a meta-analysis of over 20,000 papers. And during this meta-analysis, the key focus is to examine whether antibiotic stewardship objectives has any effect in hospitals and long-term care facilities on four predefined patient outcomes, namely the clinical outcomes, adverse events, cause, and also the bacterial resistance rates. And as mentioned, they have scrutinized over 22,000 papers, and in the end, they selected some 140 odd papers for review. And on the right-hand side, you can see a table summarizing the objectives that was being examined in this study, which comprises 14 objectives in total. And most of them are actually a common practice in the domain of the antibiotic stewardship. And in this study, they found that the overall quality of evidence remains low for the antibiotic stewardship as an overall, but then there was enough evidence to support for some interventions, namely the adherence to guidelines in administering empirical antibiotics, the IV to oral switch, the restrictions of antibiotics, say for example, the formulary restrictions, the usefulness of bedside consultations, therapeutic drug monitoring, and also the de-escalation of therapy. The overall evidence for these interventions basically shows a significant benefits for the clinical outcomes, adverse events, cause, resistant rates, and any combinations of these factors. Another paper I'd like to share with you here is about a study in the Asian Pacific regions. Again, this is a meta-analysis looking at the effectiveness of the ASP in the inpatient setting. And again, the outcome measures are clinical, microbiological, the number or volume of the antimicrobial prescriptions, and also the expenditure. And in this study, more than 600 papers were being examined, and in the end, they have selected 46 papers for further scrutiny. And among that, actually, there are two papers coming from Hong Kong. And first is about the mortality study in this paper. And as for the studies, there are actually two types here. One is the before-after trials, and the other one is the two-group comparison studies. And while in the before-after trials, the effect of the mortality is not that apparent, on the two-group comparison studies, there's actually a trend of the improvement of the mortality, as shown in the diagram on the right-hand side. As for other parameters, the pooled effect in the size of change in overall antibiotic prescription shows a drop of approaching 10%. And likewise, for the carbapenem consumption, there's a drop of more than 10%. And on the other hand, there's also a decrease in the incidence of the multi-drug resistant organisms. And in this study, they have been looking into a wide range of organisms, including MRSA, the ESP producers, carbapenem-resistant pathogens like the Pseudomonas, Acinetobacter, and so on, as well as C. difficile. And there's also a reduction in antibiotic exposure being reported, but the range of this reduction is actually pretty wide in these studies. Now, going back to Hong Kong, right? And our antibiotic stewardship program actually commenced in year 2005. And here I showed you consensus statement, which was published in the Hong Kong Medical Journal in 2006. And this is a paper with the concerted effort of the local academia and also the experts practicing in the public hospitals, highlighting the importance of the antibiotic stewardship in combating the emergence of the resistant pathogens. Now, going one step backward, what are the opportunities of interventions in terms of the guidance of appropriate therapy when the patient was prescribed antibiotics? And there are actually 3 time points. Now, when we start the antibiotics, of course, we can influence the prescriber by the provision of guidelines, education, and training. And also, there's a good clinical practice to save the appropriate specimen for microbiological investigations before the commencement of antibiotic as far as possible. And nowadays, we will also make use of the rapid diagnostics to help to guide the empirical therapy. And then around the time of, say, day 3 to day 4, is actually a time for some of the microbiological workup results to come back. So this is a good opportunity for us to see whether we can de-escalate the therapy to a low pathogen therapy. And also, it's also a time for us to review the patient's condition again to see whether we can perform an IV to over switch. And towards the end of the first week of the therapy, it's also a time for us to examine whether the patients can stop the antibiotic early. And for that matter, some of the biomarkers like the procalcitonin may give some hint in terms of whether we can actually stop the antibiotics. So we will try to examine these factors one by one. But before that, we can actually put all these factors into a framework and in terms of the practice in the antibiotic stewardship. And some of these practices are actually before the commencement of therapy. Some of these are after the commencement of the therapy. And some of these measures are actually active in nature, and some of these are passive. So we'll try to examine these measures that we are performing in Hong Kong one by one. First is about the guidelines and education. And in Hong Kong, we have corporate guidelines called IMPACT. And again, this is a concerted effort in multiple parties, including the universities, the local health authorities, and experts, and so on. And basically, this is a territory-wide guideline which was adopted by the hospital authority. Right? And apart from the paper form, you can also use an electronic form for these guidelines. And for those who are interested, you can actually try to download the app for a trial of these guidelines. And in different hospitals, they may adopt these impact guidelines based on their clinical list and modify it to suit their own purpose. And sometimes they may also produce their own practice guidelines on the antibiotic prescribing as well. Now, talking about the training and education, of course, face-to-face teaching is actually the main bulk in terms of the training and also the education of antibiotic stewardship program. And in this year, we actually also launched a program on the e-learning on the antibiotic stewardship program. And it comprises of 2 components. One is the core module, which cover the fundamental principles of antibiotic prescription, pharmacology, the concept of antimicrobial resistance, and also the allergy. And apart from that, the second component is optional modules, which cover a range of topics, including the surgical prophylaxis, infections in outpatient setting, serious bacterial infections, healthcare-associated infections, and also community-acquired infections among inpatients. And these optional modules are actually expanding in terms of the number. And for the time being, this antibiotic stewardship program e-learning is not a mandatory one. Every clinical worker can actually take their time to join this e-learning program on a voluntary basis. But at the same time, we have actually incorporated this e-learning program into our internship training. So every intern, before the commencement of clinical practice, need to go through this e-learning program in order to make them have a background in terms of the knowledge of the antibiotic stewardship program. So moving on, I'll try to talk about some IT support at the point of prescribing for our clinical users. And in Hong Kong, we are using an electronic platform for the prescription of drugs, and that's what we call inpatient medication order entry system, the IPMOE. It's a built-in function inside the clinical management program. Basically, it's used K W Choi in the public hospitals. And as I just mentioned, it's an electronic platform for the prescription of the drugs for all our inpatients. And by now, most of the acute hospitals in Hong Kong are using this IPMOE for the drug prescription. So what can we do from here? Now, first, in this year, we actually launched a function in terms of the capture of the indications of the prescriber when they prescribe the broad-spectrum antibiotics. And the targeted drugs that were included at this time point are the meropenem, imipenem, and also the piperacillin tazobactam. And when the prescriber prescribes these drugs through the electronic platform, a pop-up window will appear, and the prescriber is required to choose the indications of the drug so that we can actually capture what are the indications of the empirical therapy for that particular patient at that particular time point. And of course, with this pop-up window, we can actually serve, it can also actually serve as a kind of education and model, and also the modeling of the behavior of our frontline prescribers. And apart from that, the pop-up window showing the indications of the broad-spectrum antibiotics, there are some functions in this electronic system that can also help the prescriber to sort of optimizing the use of antibiotics. First is about the stop reminders. And the prescriber can actually key in the time interval for which the duration of the antibiotic is desired when they first prescribe the antibiotics. And by the time of the last day of the antibiotic therapy, the pop-up window will appear again to remind the condition of the patients, remind the clinicians to consider the conditions of patient and whether the antibiotic could be stopped altogether. And also the pharmacist can make use of this window to type in the relevant information to remind the clinician. Say, for example, a reminder for IV to always switch. But then these kind of functions has to be keyed in manually, so it's still not the optimal measures for the time being. And we also build in some drug sets for the clinicians to use. Say, for example, we have adopted a whole set of drugs for various clinical conditions based on the impact guideline. And this hospital drug set has been circulated to all acute hospitals. They can adopt it into use, and when the clinicians kick into these drug sets, common drugs will be popping up, and the clinicians can make a choice on the list of the agents so that they can actually be bounded by the guideline in terms of the usage of antibiotics. And also when the clinicians pick the antimicrobial therapy, the standard regimen in terms of the dosage and also the way of administration will appear, so that these common orders will also help to sort of make sure there is a consistent and safe use of these drugs upon time point of the prescribing. Still a few more functions that can help the clinicians in terms of antibiotic prescribing. One is the drug allergy checking. If the patient has been labeled, say for example, beta-lactam allergy in the clinical management system, when the clinician prescribes another beta-lactam in this electronic platform, a pop-up window will appear reminding the clinician that the patient has an allergy in the beta-lactam, so that they can actually make another choice if appropriate. And then the function is about the drug-drug interaction checking. And this drug-drug interaction checking will show a pop-up window again when two drugs being prescribed in the same patient have a drug interaction. For example, the use of a cytochrome P450 inhibitor, fluconazole, and some of the drugs that can actually be changed in the drug level by the fluconazole. So when this happens, the drug-drug interaction checking reminder will appear to remind the clinicians to consider alternative or make adjustment as appropriate. So in the future, there are a few things that we would like to work on in this electronic platform. And first is about the automation of the reminder functions, maybe for the IV to always switch or the time-sensitive stop order. And apart from that, we would also like to further sort of optimize the functions of this electronic system. And in terms of the dosage adjustment in the setting of patients with end organ dysfunction, say for example, renal impairment, and also for the dosage optimizations based on the PK/PD parameters. Now, the next thing I would like to touch upon is about the monitoring and intervention for the antibiotic stewardship program. In Hong Kong, we basically will have a quarterly reporting of the antibiotic consumption in the form of a daily defined dose per 1,000 acute bed days, the DDD, over 1,000 acute BDO as shown in this slide. And when we present the data, we try to group the agents into different groups. The group 1 is the broad spectrum antibiotics against the gram-negatives. And the group 2 is the other antibiotics with the gram-negative activities, so that we can actually take a look if there's any so-called squeezing balloon effect. And group 3 is the agents that is active against the resistant gram-positive, like vancomycin and linezolid. And apart from that, we will also capture data for all antibiotics. And all these data, we have a breakdown into individual hospitals and also the targeted departments. And the targeted departments involve medicine, surgery, orthopedics, and also the intensive care units. And apart from the list of antibiotics I just showed you, we also capture data on the last resort antibiotics, like the colistin, ticagrelin, daptomycin, and so on. And this list of research drug is also an expanding one. In the future, we will include the newer agent like the ceftazidime, avibactam, and so on. And again, this list of drugs will have breakdown into the level of individual hospitals as well as the targeted departments. So talking about the interventions on ASP, there are basically two main types. One is the pre-authorization of antibiotic prescription. The good thing about this pre-authorization is that it's having a direct control over the antibiotic use. And of course, it can reduce the initiation of the inappropriate antibiotics and optimize the choice of empirical therapy. And but then the downside of this approach is it can only provide impact on the drugs being restricted only, and basically address more on the empirical use rather than the downstream use. And the prescriber may feel a loss on the autonomy, and because of the process of pre-authorization, there may be delay in terms of the starting of the therapy, and one can actually imagine the real-time resources could be very intensive if you want to exercise this pre-authorization. And also there's a potential for manipulation of the system in order to gain the authorization. Well, in Hong Kong, we by and large practice the prospective audit and also the concurrent feedback in most of it, if not all the hospitals in the public sector. And the good things about this approach is that we can increase the visibility of the ASP team and also to build up the relationship with our colleagues. And by the time the audit was performed, there will be more clinical data available to make the recommendations. And also this allows a greater flexibility in the timing of recommendations. And through the interactions, we can provide the educational benefit to our clinicians. And on the other hand, the prescriber's autonomy can be maintained. And apart from the control of the empirical therapy, it can also address the de-escalation of the treatment and also the duration of the therapy. However, the downside of this approach is we cannot guarantee the compliance because the process is basically the acceptance of this feedback and advice is voluntary. And it's also labor intensive because of all these interactions with the front-end prescriber. And the prescribers may be reluctant to change the therapy if the patient is doing well. And also when compared with the formulary restrictions or pre-authorization, the effect on the control of the targeted antibiotic use may be less apparent when we adopt this approach. Well, either way, we need the tool to help us to capture the patient's data and also to facilitate the monitoring. And in the hospital authority, we'll have a built-in electronic platform for our back-end users to capture the patients who have been prescribed the antibiotic therapy. And this antibiotic audit form is actually electronic, and they have the patient's clinical and also the demographic parameters being filled automatically. And some of the laboratory parameters will also be available in this lab form in the automatic manner. So since the usage of meropenem and piperacillin tazobactam is among up to 70% of the empirical antibiotic use choice of the broad spectrum agents. So these are the targets for our review process. And through the process, we will also provide appropriate advice and feedback for our frontline conditions. And in addition to this, ASP team will review all cases who have the last resort antibiotic prescriptions, say for example, for patients who are receiving colistin. And of course, we will also give recommendations on indications of new and reserved antimicrobials for the multi-drug resistant organisms. So the monitoring of the piperacillin, tazobactam, and meropenem is a baseline. If time and resource allow, the ASP team, of course, can have more drugs to be included in terms of their targeted antimicrobial for interventions. So this graph just showed you the rate of the appropriateness of the antibiotic usage, as well as the acceptance of the advice given by the ASP team in the year 2018 to year 2019. We capture these data in a half-yearly basis. So from this graph, you can see that the blue line is the percentage of appropriate prescription. And there's actually an improving trend being seen here. And for the acceptance of the advice, the response rate is a bit vary over time, but at least it's over 85% for most of the time. So moving on, I would like to touch upon the laboratory support for the implementation of the ASP. One thing that we have introduced in recent years to facilitate the ASP is the procalcitonin assay. And the procalcitonin assay as a marker for the information can help us to decide whether the drugs can be stopped early, and as well as whether the drug should be initiated at the beginning. But then the former perhaps is more important in our clinical practice. I'll show you in the next slide. And for the time being, the procalcitonin has been verified in various studies in terms of their usefulness on the antibiotic stewardship, right? And as you can see here, for the meningitis, pneumonia, the upper respiratory tract infections, and patients with septic shock, we have actually data in terms of the intervention studies for the diagnosis and as well as the ASP. And on that hand, we also have data on the urinary tract infections, bloodstream infections, abdominal infections, and post-op infections for the diagnostic or observation studies. As I've just mentioned, one of the usefulness of the procalcitonin is to help us to stop the antibiotic early. Right? Well, actually, in the past 10 years or so, we have ample data to suggest that many of those common infections that we encounter day in and day out, we can actually limit the course of the therapy to a much shorter time as compared with the previous recommendations. Here is a table extracted from an editorial from JAMA 5 years back. And as you can see, many of these common conditions, we can actually give a shorter course of antibiotics. So by use of the procalcitonin, we can actually give extra evidence for our clinicians to stop the antibiotic early. And through this way, we can also try to promote the concept of less is more in terms of the antibiotic usage. Now, I would like to mention one more thing that for the time being, we just practice it in a small scale, and that is the use of rapid diagnostic on the ASP. And for example, in the hospital cluster that I was working with, we have a rapid test for the diagnosis of MRSA for the bloodstream infections. And this is one example for the application of the rapid diagnostics on the ASP. And compared with the traditional empirical therapy while waiting for the microbiological workup result, the rapid diagnostics can actually give or enable a targeted treatment right at the beginning. And it can also help to reduce the use of a broad spectrum or unnecessary treatments and avoid failure to treat the right pathogen or resistant profile on the other hand. So this is an area that is worth exploring in the future. So putting all the elements that I've mentioned together, and here comes the service model that we adopt in the public hospital. Now, of course, at the starting point for the frontline clinicians in the targeted departments that I've mentioned, ICU, medicine, surgery, and orthopedic, when they try to prescribe antibiotics, we actually prompt them to observe two things. One is to order appropriate microbiological investigations, and second is to prescribe the drugs according to the local guidelines. And when they perform the laboratory test, of course, result will be available in a few days' time. So the antibiotic stewardship team will come into action at about day 4 of the initiation of the treatment. And they will try to audit the case and review the appropriateness of antibiotic use. And if necessary, they will provide concurrent feedback to the clinicians. And yes, also at this time point that the ASP team may order the PCT for the clinician, right, in the way as to help to dictate whether the antibiotic will be stopped earlier in the later part of the patient management. So apart from this frontline clinical work, the ASP team will also compile and issue reports which will consist of the appropriateness of the empirical use of antibiotics, the percentage of the compliance to concurrent feedback, as well as the antibiotic consumption data. And all these reports will be shared to the department heads of the targeted departments, and as well the antibiotic stewardship team member will present the findings in the Drug and Therapeutic Committee or Infection Control Committee in order to draw the attention of the senior management in terms of the performance on the ASP, as well as the trend of the antibiotic usage. So may I reiterate again the key points for the prescribers for this model. We try to ensure the appropriate clinical specimen for the microbiological workup were taken. And of course, the better way is to do it before starting of the therapy as far as possible. And we emphasize on the choice and dose of the antibiotic treatment according to the local guidelines. And the clinicians are reminded to observe the IV to O switch as well as the de-escalation of the therapy as far as possible. And last but not least is try to avoid prolonged treatment duration that is unnecessary. And again, for the outcome marker, the data that we try to capture and disseminate are number 1, the percentage of appropriate use of empirical therapies. Number 2, the percentage of compliance to concurrent feedback. And number 3, the antibiotic consumption data in the form of a DDT per 1,000 acute patient bed days. So finally, I would like to share with you the challenges that we are facing nowadays in practicing of the ASP. Just like most of the clinical programs or initiatives in the public sector, sustainability is often a big issue, and for ASP is also of no exception. For the ASP team, we often encounter a problem of growing workforce that was not matched with the service demand. And also, the ASP team leader often is the ID physician or the clinical microbiologist. They often multitask and need to take care of different sort of problems. Say, for example, for the microbiologist, they need to take care of the lab-related matter and also the infection control policy. For the ID physician, they may also need to take the other part of the clinical care for the patient as well. And the increasing diversity, complexity, and volume of the workload means that we are having a limited resource for the implementation of the ASP in the perspective of the ASP team. As for the budget holders, they are facing up the shortage in manpower locally, both in terms of the doctors and nurses and so on. And at the same time, there are often other competing interests within the healthcare sector that they may need to take care to and inject the resource in. On the other hand, the effect of the ASP may not be directly tangible for the budget holder. Say, for example, even if we have the ASP in place, sometimes the rates of the MDRO, the multi-drug resistant organism, may not show a apparent drop. That's the reason why the budget holder may not feel the importance of the ASP. And this, of course, will have an implication on the resource allocation to the ASP team, and also that will affect the practice adversely. As for our collaborator, the frontline doctors, they are facing up with an aging population in Hong Kong, and often they are having multiple comorbid conditions and chronic illnesses. And also, we are facing up with an expanding population of the immunocompromised individuals, say, for example, the cancer patients, and those people who are receiving biologic therapy for the immunological disorder and so on. And in this locality, we are also witnessing a rise of the MDRO. For example, in recent years, we are seeing more and more the carbapenemase producing antibacteriaceae, and also the threat of the multi-drug resistant Acinetobacter is always there. So from the perspective of the frontline clinicians, they are often a pressing need of a broad spectrum antimicrobial for treatment, both in terms of the empirical therapy or pathogen-specific therapy. So as you can imagine, sometimes there could be a conflict of interest between the ASP team and also the frontline doctor. So by now, I hope that I've shown you what we are doing here in Hong Kong in terms of the practice of antibiotic stewardship and our rationale behind. With this, I would like to draw this presentation to a close, and thank you for your attention.